Hi, welcome to Inova Talk. I'm Dr. Chuck Murphy, your host, and we're streaming live from Inova Fairfax Medical Campus in Falls Church, Virginia. We're very lucky today to have Dr. Rich Neville with us, who is the System Director for the Inova Heart and Vascular Institute Vascular Program. Rich, can you take a few minutes and introduce yourself, please?
Sure. Thanks very much, Dr. Murphy, for asking me to come this morning. Yes, as you said, I'm the Associate Director of the Institute here and in charge of vascular services across the system. So what are vascular services? Well, it really involves all of the blood vessels outside of the heart. So we deal with every blood vessel outside and not including the heart.
Okay, thank you. And as we get started here, I want to ask our listeners to please put your questions in the comment section and we'll try to answer them live. And as always, please keep in mind that this information is really only meant to be informational and not intended to replace the advice that you get from your own physician. Let's just get right into it. What is peripheral artery disease, or PAD?
Yeah, so great question, Dr. Murphy. So in your body, there's two kinds of blood vessels. There's arteries that take the blood from the heart to the tissue, to the leg, to the arms, to the brain, and there's veins that take the blood back from the body and the tissue back to the heart for the heart to do its job. So PAD stands for Peripheral Arterial Disease. So this is blockages in your arteries, not in the veins. So this is blockages in the blood vessels that take the blood from the heart to the tissue, because the tissue needs to have nutrients and oxygen to survive and perform its functions, and the arteries supply that. Well, if you get blockages in these arteries, which is due to atherosclerosis usually, and atherosclerosis is hardening of the arteries, much like you get in your heart, then the blood flow can't supply the appropriate oxygen and nutrients that the tissue needs, and you have symptoms. So peripheral arterial disease is blockages in your arteries that impact the tissue that the arteries supply.
And so what causes those blockages? What causes PAD?
So most of the time it's due to atherosclerosis, which is deposits in the wall of the artery which causes narrowings and sometimes total blockages to impede the flow through the artery or the tubes carrying the blood to the tissue.
Okay, and are some people more susceptible to PAD?
That's a great question, Dr. Murphy. So yes, if you have a history of smoking with tobacco use, and especially nowadays, diabetes. So diabetics are prone to this condition, especially in their legs. And diabetes, as we know, unfortunately, is exploding around the world. So really, people who have diabetes, people who have smoked or are smoking, and also people that have had a history of having heart issues in the past possibly could have some blockages in their arteries, usually their leg arteries.
And then how about high blood pressure, kidney problems related to high blood pressure?
Yep, so high blood pressure is associated with it, and people argue about whether it's causative or not, but we oftentimes do see people that have both high blood pressure and PAD. Kidney failure is a little different. Kidney failure often goes along with PAD because it sometimes can be related to the same process, but they're not causative.
Okay, and then I guess in light of your answer, it would seem that there are things that one could do to help prevent the development of PAD?
Yes, there are. So that's called risk factor modification. So what we want to do is we want to reduce your risk so that you don't develop PAD during your lifetime. And the risk factor modification involves many of the same things you've heard about with heart disease. Actually, the American Heart Association has done a great job at publicizing what you can do to try to prevent this process in the future. So that includes things like try to stop smoking, get your diabetes evaluated and treated. There's a lot of people walking around in the country that don't know they have diabetes, so to be evaluated for that. And also to maintain your exercise program, maintain your activity. And also there's many medications now that have been shown that can be helpful, including statins. So the statin agents are oftentimes helpful. And also the antiplatelet agents, things like aspirin, can be helpful in certain settings.
Okay. And then actually I want to jump right into something I think that's real important, because I think many people in our audience will be aware that you can have really emergency blood vessel problems to the heart, a heart attack, or to the brain, a stroke. But I think that there is not as much awareness of what really can constitute an important emergency with the blood vessels to other parts of your body, but are equally important to deal with right away. So can you talk about that?
That's also a great question. So awareness is a real issue with PAD, and we're trying to fix that, because PAD in many studies seems like it's growing and becoming more problematic than heart disease. So we've not done well with our awareness over the years, and that's both to physicians and doctors. There was actually an interesting study out of Britain that showed British doctors didn't know they had PAD when they went to their primary care doctor. So yes, we need to raise awareness of this disease process, no question.
But if all of a sudden I'm at home and my leg gets cold, or I can't move it, or whatever, I mean, that's a medical emergency, right?
It can be, it's not always. So that goes to the symptoms. So what kind of symptoms would you have of PAD? Well, some people don't have symptoms, and that's why it's important to work with your primary care doctor. There are screenings that you can do using ultrasound and just some simple non-invasive tests with a little bit of jelly on your skin and some ultrasound to see how your legs are doing primarily and see if you have PAD. If you do develop symptoms, the first symptoms is usually called claudication. So what is claudication? Which some people think was named after the Emperor Claudius, because he limped. So claudication is pain when you walk. Now, a lot of people have pain when they walk, and they may not have claudication. So this type of pain usually occurs in the lower leg. It doesn't occur in your back or your hip, usually. And it occurs when you use the leg. So you use the leg. The muscles in your leg say, hey, body, send me some more blood. And the blockages won't allow that to happen, so the muscles have to function without oxygen, and you get pain. It doesn't usually happen, it's not a cramping pain that you get at night. That's usually your veins. So it's usually a pain that occurs when you walk. The other thing about claudication is it's very reproducible. So it happens at the same distance every time. It doesn't happen when you walk 2 miles one time and half a mile the next time, because the body doesn't change that dramatically. So it's usually a very reproducible pain in your lower leg when you walk.
Okay, and I'm glad you brought up the cramps at night, because one of our questions from our listeners actually was about cramps that occur at night, and as you said, that actually is different than what we're talking about with claudication from peripheral arterial disease. So I think that that's an important thing for our listeners to be aware of. And so if I think that I might have PAD, if I'm having cramping when I walk, then I would, what would your recommendations specifically be?
Right, so if you think you have PAD, then you need to see your medical doctor and get some simple some simple ultrasound tests to see if you do have PAD and how critical it is. Because the thing we want to avoid, to your former question, is more of the emergent situation. So what happens next? So if you have this claudication pain, which occurs when you walk at a certain distance every time, and by the way, it usually gets better when you stop and rest. It doesn't persist as you rest, because when you rest, the muscles don't need the oxygen anymore, and they say, okay, we're back to our baseline status. So it usually stops when you rest. What we want to prevent is something called critical limb ischemia, or CLI. You might see that in papers and the newspaper and things. So CLI is the next, is PAD, which has gotten worse. So what is CLI, or critical limb ischemia? What that means is now the tissues of the leg don't even have enough blood supply to function when you're not walking, when you're not using them. So you get pain at night. But this is not cramping pain. This is really bad pain, usually in your foot, almost like a really bad toothache of the foot. And people will hang their leg over the bed so that gravity pulls a little more blood into the foot and stops the pain. Or they'll sit up in a chair and they'll tell you that that makes the leg feel better. So if you have pain, usually in your foot, At night, usually, because at night your heart output drops a little bit and the blood flow to the leg is a little less, and that's usually when people notice it. This sometimes occurs with color changes in the foot. The foot can turn sort of cold and kind of blue and discolored. So obviously if you have that, that's an urgent situation and you need to see a vascular person or your primary care doctor quickly. The next step after that, if we don't do something about that, and that's called rest pain, Dr. Murphy. So
Okay.
you have claudication and then there's rest pain, pain at rest. Bad toothache in the foot gets better when you hang your leg over the bed. If nothing's done about that, then a large number of people will go on to develop what we call tissue loss. And unfortunately, I have all too many people come into my office with this condition. Again, I think because of a lack of awareness. They come into my office and they have wounds that won't heal. Or sometimes they actually have gangrene or dead tissue on their foot because they just didn't know what to do. At that point, then we really have to do something to save the leg, or you can end up with an amputation or losing the leg. And that's really what we want to avoid. I'm on the board of an international society, the CLI Global Society, to really make an impact around the world on amputation prevention. That's one of our main goals, is to prevent amputation in the United States. So it's claudication. We can help you treat that. Risk factor modification. Exercise is good for claudication. And there's one medicine that can help a little bit, which I usually try in people. If we can't stop it there, the next thing is this rest pain. Pain at night in your foot, it'll keep you up. You won't be able to fall asleep. Gets better when you hang your leg over the bed. And then hopefully we can do something before you develop wounds or gangrene on the leg, and then we really have to get some more blood down there to save the leg.
It's interesting. We have a pretty sophisticated audience, Dr. Neville, because someone was asking about exercise and walking if they, as sort of a non-medical, non-surgical treatment, and then also about using weights and such. So, but you were saying that exercise actually is good if you have claudication.
No question. If you come to my office and you have claudication, what we'll do is we'll check some ultrasound studies. If the ultrasound studies show that your blood flow is okay and not so low that I'm worried about you losing the leg, which is usually the case, then I'm not going to operate on you. I'm not going to put a stent in you. Some patients come into my office saying, hey, can I have a stent? And it's not the right thing if you just have claudication and your leg's not at risk, because stents have a downside too. They can fail over time. So initially, Dr. Murphy, we try to institute a walking program. We get you to stop smoking. We help try to control your diabetes. Maybe we'll add a statin medication if you're not already on it. And really, there's another medicine called Platol that helps about half the people. So I'll institute all these medical therapies, including exercise, that's critical, and I would see you back in 3 months. And we'd see how effective it is, and then we'd follow you.
And then as we're getting into the treatment realm of the discussion, I wanted to first talk about the structure of that and the fact that it's actually a team of specialists, and maybe you could talk about the team that you've assembled that helps make certain that the patient gets the right therapy.
That's a great question as well. So I've spent my career working on building this kind of a team, because when I first started in practice 30 years ago, I found very quickly that patients that have this problem, PAD, especially critical limb ischemia or CLI, have all these other issues. They have a lot of other medical issues, and not one person can handle all of them. So we really put together teams, and we put together a world-class team here at Inova, which includes people that can treat the blockages in the arteries, can treat the medical condition, can treat your diabetes, can assess your heart to make sure your heart's okay. Because let me tell you, probably one of the major issues and one of the major risks of someone who has claudication, pain when you walk, may not be losing your leg in your lifetime, but may be that you also have the same process in your heart and you may be prone to have a heart attack, or the same process in your neck arteries and you may be prone to a stroke. So that's part of this awareness problem. Even if I never put a stent in your leg or operate on your leg, if you have claudication, I would say that that's our opportunity to treat this disease process so that you always keep your leg, you don't have a heart attack, and you don't have a stroke. So we've assembled a team of world-class experts just around this disease process, whose goal is to prevent amputation, but also to treat these patients in a multidisciplinary team approach.
Maybe if you could actually even delve a little bit deeper and tell us some of the specific roles that entails, like interventional radiology, vascular medicine specialists.
Yes. So it all starts with medical therapy and reducing your risk factor analysis. So we want to make sure your heart's okay. So we have cardiologists and heart doctors who are intimately on the team. We have diabetologists. We have a world-class diabetologist who would help with our diabetes. We've got nephrology or kidney experts that can help us if there's problems with the kidney. And then we have people assembled just to treat the vascular problem. So that would be people such as myself, who are vascular surgeons. And vascular surgeons can do both what's called endovascular therapy. That's using small catheters through little needles in the leg or the arm to open up these blockages, sometimes with a stent, but sometimes not. There's many options. Or about 25% of the time, I do end up doing standard surgery, which is usually a bypass in the leg. And we've developed some bypass techniques which I think are world-class and other people around the world are following. So the vascular doctor, who could be an interventional radiologist to help us with the catheter or endovascular procedures, and then vascular surgery who do any type of surgical procedures, including bypass, that might need to be done to treat the condition.
Okay, and at least in the past, I think that the treatment you got might be decided based on who you saw. So if you saw a vascular surgeon 10 years ago, you might tend to get a vascular surgical procedure. If you saw an interventional radiologist, you would tend to get a stent. But I think with this team approach, you're really trying to make certain that the patient gets the correct therapy for them based on what their situation is.
That's a great point. So first of all, as you may remember, if you come to my office with PAD, most of the time we're going to treat you medically with exercise, stop smoking, get your diet. So most of the time people don't need a vascular procedure. But we have instituted a multidisciplinary conference, a case conference, where we discuss cases and share cases amongst the different specialties, Dr. Murphy, as you said, so that people really can get the ideal procedure for them, not driven by what office they end up being sent to.
Great. And I think that at Inova we have multiple different places really throughout the community that people can go.
That's also a great question. Yes, so one of my initiatives upon arrival at Inova a couple years ago was to really systematize our approach to vascular disease, to make certain that across our hospital systems you'll be treated in a similar way according to data and according to the best information we have. And so all of our hospitals have the ability to perform most of the procedures. Some of the higher end procedures come to certain of the hospitals, but our goal is really to offer these vascular services across the entire system in a very similar way, so that it doesn't take the variation out of the therapy. You should be treated the same way whether you go to Fairfax or whether you go to Alexandria or Loudoun or Fair Oaks or Mount Vernon.
I think the other thing that strikes me is how fast things are changing in the vascular, surgical, and interventional world with new technology, new treatments. So maybe you can touch on that and how you look at that with regards to the vascular services at Inova.
Also a great question. So yes, the vascular world is dramatically changing. Technology is, as you might expect. I mean, look at your iPhone. Look at all kinds of technologies we interact with on a daily basis. I just got an iPhone, by the way. But
you were using
just
a flip
kidding.
phone.
Yeah, I was using I was dialing on a rotary, but no, just kidding. But no, technology is exploding, and so Inova wants to be at the forefront of that, and that's a big interest of mine. So yes, we're investigating many kinds of devices which will become even less invasive, will allow our procedures to be successful for a longer period of time. And also, one of the things I'm very excited about is using micro technology to actually monitor your health status. remotely so that this information can be transmitted to your physician, giving you an update on your health status remotely, which was very exciting.
Yeah, I'm glad you mentioned that, because I think one of the questions I wanted to ask is, once I have peripheral artery disease, then there's a follow-up that's very important.
Yeah, absolutely. So yes, so if we decide to do something, the patient and myself, if we decide that either angioplasty or a stent or a bypass operation is appropriate to either relieve pain or to save the leg, and those are the two reasons. Unfortunately, I see all too often people go and have ultrasounds done and shows that there is a blockage and have the blockage treated just because it's there. And that's not appropriate. So there are two reasons for me to ever put a stent in someone or do an angioplasty on someone or do a bypass on someone is if they have pain we're trying to relieve or we're trying to save the limb from amputation. Those are the two reasons. And why just those two reasons? Well, because anytime we do a procedure on the leg, these procedures can fail. You get something called hyperplasia, which is kind of like scar tissue. It's not really scar tissue, but you can think about it that way. And this hyperplasia grows into the area where we've been working and can reblock the thing that we've done. Now, it doesn't happen often, but it can happen. And it's much easier to fix if we see it happening before it totally occurs. So what I always tell patients is, if I ever operate on you or put a stent in you, we're going to be good friends over the years. It's not the kind of thing where we do this and say, okay, see you later, let me know how you do. No, there's a very close follow-up. We want to use, again, our ultrasound techniques and our physical exam to check what we've done on a fairly routine basis. So I'll see people back in 3 months, in 6 months, and then annually. The other good thing about that is it lets us keep a handle, so to speak, on the person's overall cardiovascular health. So, I can yell at you if you're still smoking. Just kidding, I don't yell, but I can say, listen, you really got to stop smoking, or you got to get to the cardiologist. They got to check your heart. So it gives us a time to interact about your total cardiovascular health, but also to check what we've done to make certain that you're not one of those 10 or 15% of people that are going to need something more done to keep things working.
You keep throwing little nuggets out there, and I'm trying to keep track of them, but one of the nuggets, I think, was you sort of touched on shared decision making, that it's really you making a decision with the patient about the course of treatment based on best evidence.
Absolutely. So it's really a two-way street. I think for vascular disease, more than much, maybe. The only time I'm going to tell someone they really have to have something done is if I think they're going to lose the leg or lose the limb if we don't. Then I'm going to say, look, we need to fix this for you, because if you do lose the limb or lose your leg and have an amputation, all the studies show that that's actually worse for your long-term health overall than if we can fix it. So the only time I would say, listen, you really have to have something done, is if I think you're going to lose the leg. Otherwise, it's very much a shared decision, whether we use medical therapy, walking, medications, or whether we do some procedure for pain relief. So what I tell people is, when they come into me and I see them for the first time in the office, we institute the walking program, try to get you to stop smoking, get your diabetes checked, make sure you're on the right medicines, make sure you see a heart doctor if you need to, and then I see you back in 3 months and I tell the patients, you're going to tell me. You're going to either say, I'm fine, let's keep going, which is great, or you're going to tell me, nope, the pain is still too much, we need to do something.
Then I was thinking, as we were talking about that technology is advancing, and of course then we have to provide evidence that that's actually a good thing to do. So there is a potential that patients that come and see you with PAD might have the opportunity to be in trials related to some of these new treatments too. Can you?
That's exactly correct, yes. So we're actively engaged in research, which really, again, makes the program world-class. You have to be involved in research and education. You can't do just clinical care, although I love it. That's my main passion. But you have to have that research and that education piece. It just elevates the whole program. So to your point, there's several trials, world-class, cutting-edge trials, which people can become engaged in if they wish.
Great. Okay. And I think at this point, I think maybe go and have you, Dr. Neville, review some of the key points from the discussion. Maybe start with, again, I'm very interested in sort of the awareness of emergency problems that would trigger that someone really does need to seek urgent attention.
Right, so the first step is just, and it's for vascular surgeons as well as the healthcare system, is just to raise awareness. So we were just at a meeting not too long ago with CMS, which is the governing healthcare institution, trying to emphasize to them they've done a great job with heart disease. We need to also now do a great job with PAD so that people know what the symptoms are, people recognize the symptoms, recognize they may be prone to the symptoms, so that they can get a very simple screening study, which is basically, as I said, just some jelly on your skin and an ultrasound test to show if you have it or not, and if you do, how bad it is. And then avoiding the emergent situation involves good medical care, exercise, stop smoking. Now there will be some people that the artery blocks suddenly. That can happen, and those are these emergency situations you're talking about. That can occur, and if that were to occur, then the best thing to do is just get to the emergency room as soon as possible so we can fix the leg before you lose it. What would the patient notice? The patient would probably notice a significant change in symptoms. So let's say you just had pain when you walked, which occurred at half a mile, got better when you stopped, you didn't want anything done about it, but then one day the leg suddenly started to hurt even when you weren't walking, it changed color, it got a little cold. That's not a good thing. So then you need to come quickly to the emergency room.
Because you basically have 6 or 8 hours till you can have some permanent.
Yeah, people argue about that 6 to 8 hour number. I don't want that to be, but certainly we need to do something as soon as possible.
Okay, yeah, fair enough. And then, so now we've talked about that, again, in sort of reviewing that we have the ultrasound, we have PAD, and I think then you talked about the team that would help assess what the best options are, and maybe you could just run through the treatment, the highlights of the treatment again.
Yes, exactly. So if we decide that you do need something done, and beyond medical therapy and walking and stopping smoking, then what we have to decide is what's the best procedure for you. So that involves a little more imaging first. So we may order a CAT scan for you, which will take a good picture of the arteries, or we may even get what's called an arteriogram, where we put a small catheter into the artery and inject some liquid, which gives us exact pictures of the circulation. So why do we do that? Well, that's sort of like your roadmap. If you're making a long trip, you need a roadmap to tell you how best to get there. Although with Google Maps these days, maybe you don't, but even Google Maps has maps. So you need a roadmap to tell us what the best solution is for you. And the two choices would be what's called endovascular therapy, where we'd put a catheter into the leg artery usually, and then use angioplasty, a balloon, to open up the blockage. And then sometimes we use a stent, sometimes we don't. Sometimes you can use a device to shave away the blockage. That's called atherectomy, although we don't use that too often. But some form of therapy based just on a catheter, minimally invasive, most people go home the next day. If the blockages are so extensive and in the wrong location that endovascular therapy doesn't look like it would be effective, then we still do standard bypass techniques where we'd go to the operating room, I'd make an incision usually up in the groin area, because that's usually where the blood is good, and then we would do a bypass or reroute the blood to an artery farther down to accept the blood to take it into your leg. And we can do this either with your own vein from your leg, sort of like they do with heart bypasses, but we've also developed at Inova a technique to use a man-made tube and make the man-made tube work much better than it did in the past, so that we have that option as well. The reason we might do that is if your vein is kind of small and not good for a bypass, and also we can do it through very minimal incisions, so we can do a bypass in a minimally invasive manner.
Okay, and then I think we also talked about following that up, that patients will have that vascular team that will be following them on a regular basis with any of these therapies that they get.
That's exactly right. The team will obviously descend upon the patient in the hospital, and then we'll follow the patient as an outpatient to make sure that whatever we do continues to work well.
And then I think that for our audience, if we want additional information about PAD, we can visit the website inovaheart.org/PAD. And that was a resource for people getting more information. If you need more assistance actually locating a physician, you can visit inova.org/physicians. Or lastly, you can call 1-855-MY-INOVA, which is 1-855-694-6682. And so we hope you've enjoyed this session today. I will mention that if your question wasn't answered, we will try to actually still go and provide an answer to these questions over the next period of time. We greatly appreciate your time and attention, and certainly wish you to be very healthy moving forward. Thank you.